Okay. Ready?
Yes, a 72-year-old woman comes to the physician. A 72-year-old woman comes to the physician because of 1 year history of aching and stiffness of her right arm and progressive difficulty walking. She also says that her voice is becoming soft. She has some choking when she drinks water rapidly. She appears somewhat apathic. Examination shows 6 by 6 brown nevus on the left shoulder. She has a lack of spontaneous movement. There is increased muscle tone in the right upper extremity and resting tremor of the right hand. Which of the following is the most likely diagnosis?
Brown nevus. Oh, what's my pen?
Increased muscle
Hmm. Is it neurofibromatosis or metastatic melanoma? I don't even know how metastatic melanoma. Where does metastatic melanoma goes? Choking water. Choking away his
tone. But
drinking. What?
lots of symptoms similar to
Oh,
Parkinson.
to Parkinson. But Parkinson, there is no upper extremity increase upper muscle tone. That's
Yes,
not
that's
Parkinson.
true.
And there is no. What is the brown
Pro
nevus thing? The
ne-
brown.
neurofibromatosis can happen, but it should be diagnosed earlier.
Are
Or
there
just sorry,
upper motor neuro thingy in neurofibromatosis? Upper
don't
motor, yes, I
don't
don't
think
know.
so.
Three.
Neurofibromatosis type 2, hemangioblastoma,
Uh-huh,
angiovetosis, renal cell
uh-huh.
carcinoma, fibroma,
And then that's the schwannoma. Um, maybe it's metastatic melanoma.
melanoma, upper motor resting tremor.
Okay,
But
let's
why?
pick.
But is there any possibility of having ALS?
With the nevus, what does ALS have to do with the nevus?
And just keep the nevus. Nevus can
Is that-
present. Nevus can present in anybody.
Okay.
If nevus is significant, he would die within this age. So your
Oh,
answer is metastatic melanoma.
oh, okay, maybe not. I don't know when. I don't know how metastatic melanoma presents. I don't know. So okay, you say ALS. ALS will be upper motor neuron and lower motor neuron. Upper motor, yes, we see she has
A-
the upper extremity thingy.
And there is dysphagia, vulvar involvement. There
Okay,
is
okay,
no lower motor, but there is vulvar involvement.
okay. I guess if you don't think about the nevus, okay, fine. Maybe it can be. Okay, pick one. Let's.
Very, very okay.
Oh my God.
My
You were
first observation was right.
not
Parkinson.
that I would have never gotten this question correct.
Initially, I was going through Parkinson, because Parkinson. Okay, no problem. I know this type of question can hamper.
Parkinson's disease, progressive neurodegenerative disorder caused by degradation of dopamine in the suspension nigra. Symptoms associated with imbalance of dopamine and acetylcholine
These
result.
neuro questions are harder than
They
the
are.
you world.
Yeah, 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 they are. Resulting in characteristic finding of bradykinesia, resting tremor, rigidity, postural instability. Okay, doesn't have all that. Okay, fine. Psychiatric disturbance, sleep disorder, dementia, in addition to prominent motor symptoms. Is Parkinson associated with accumulation of alpha-nuclein, synuclein protein, which develop neuronal homeostasis and leads to neuronal death. These Alpha synuclein inclusion, also called Lewy bodies, are circular eosinophilic cytoplasmic inclusions that lead to destruction of dopamine neurons in the substantia. Consequently, the basal ganglia, which rely on dopamine input from the substantia nigra, cannot properly modulate voluntary movements, resulting in cardinal Parkinson's symptoms. Treatment centers around increasing central nervous system dopamine levels, such as carbidopa level. Okay, so the nervous wasn't even like it was what the distractor.
Yes, nevus was a distractor because my observation is if somebody has like nevus in the early age, it turns into melanoma, he will not gonna survive up to 72. And
Oh,
there are some people who has like nevus or like black spot in the face and it persists lifelong. There are plenty of person.
and then the choking, and then the upper
The,
motor neuron
the
dying.
choking can happen in the Parkinson also.
Jesus. And then
So
upper motor neuron.
they are actually thinking upper motor neuron like muscle tone is increased. This can be explained by the age also. In the we have found one question where age is the like he has a Babinski like which Jark was positive, but he is normal. There was one question in these CMS form.
Jesus. Okay.
These things are very complicated
Yeah, that's no, I would never found this question. Okay, it's not metastatic melanoma commonly involves the brain. Oh, it
because
goes to
you
the
because you can't made well, you can judge this question by the observation. Okay, okay,
brain
let's see.
metastasis.
We can exclude other options.
Yeah. Metastatic melanoma commonly involves the brain. Brain metastasis typically present with focal neurologic deficit, headache, seizures. Okay. Lesions are typically localized at the gray-white matter junction and associated with significant edema, vasogenic edema. So it goes to the brain, neurologic headache, seizure, and edema. Neurofiber NF1 presents with constellation of findings, so including neurofibromas, cafe au lait macules, that's what I thought it was. Axillary freckling, optic nerve glioma, iris hematoma, which is Lynch nodule, lumbar hypodysplasia, neurofibromatosis, two different constellations. You see the acoustic neuromas, cataract, meningiomas, ependymoma. Okay, I guess it's not that. In ALS, you'll see affects the anterior horns and the corticospinal tract. So patients demonstrate a combination of upper and lower motor neuron in an asymmetric distribution that may include the bulbar muscles. I guess, yeah, that's kind of why you were saying that it may be this also. Okay, yeah, this question was, yeah,
Pretty hard.
yeah. Next.
4 weeks, 4 weeks ago, a 58-year-old man. 4 weeks ago, a 58-year-old man developed drooping of the right upper eyelid, and double vision. Over the past week, he has had difficulty swallowing, especially at the end of a meal, inability to sustain a conversation, weakness of the arms, and when he shaves in the morning. Examination show incomplete adduction of the right eye when looking, incomplete adduction of the right eye when looking at the left. He has nasal speech. Which of the following is the most likely diagnosis? Drooping of the
Adduction of the right eye, drooping of the upper eyelid,
nasal speech.
nasal speech. Myasthenia gravis, myasthenia lumbar eaton. Say worse at the end of the meal. Myotonic dystrophy. ALS. Okay. Ready?
Yes, it is MG,
I think.
myasthenia.
Let me see. What is the answer? Yeah, it's myasthenia.
Okay.
This patient presents findings of intermittent ptosis, diplopia, reduction in extraocular movement, suggestive of MG is a B-cell autoimmune disorder characterized by formation of inhibitory acetylcholinesterase, no, acetylcholine receptor antibodies. Patients typically have muscular weakness and fatigue that worsens toward the end of the day, as well as oculomotor symptoms, drooping eyelids, diplopia. Many patients with ocular findings are later develop generalized involving the muscle, the proximal muscle. In severe exacerbation like myasthenic crisis, patients may develop weakness of the muscles of the throat, diaphragm, chest wall, leading to dysphagia and acute respiratory failure. Myasthenia gravis is diagnosed with the detection of serum antibodies. Chest X-ray is useful for detection of thymoma, which frequently produce the myasthenia gravis as paraneoplastic phenomenon. Some patients experience resolution of symptoms after resection of the thymoma, although some patients require treatment with steroids and acetylcholinesterase inhibitors. Myasthenia crisis is treated with IV immunoglobulin, plasmapheresis, intubation, mechanical ventilation. It's confused with something else. It's not ALS, progressive neurohalma, upper motor neuron, lower motor neuron, um, accompanied by muscle weakness. Okay. And it's not myotonic dystrophy, genetic disorder caused by expansion of the trinuclear repeats. Which trinuclear repeats are these ones? By muscle, characterized by muscle weakness, myotonia, cataracts, muscle weakness, myotonia, cataracts, frontal balding, cardiac arrhythmia, and hypogonadism. Most frequently affected muscles include the facial muscles, sternocleidomastoid, distal forearm muscles, intrinsic hand muscles, and ankle dorsiflexors. What's the trinucleate for myotonic dystrophy? Is it, wait. No, I don't, I have no idea.
Myotonic,
MTD?
myotonic dystrophy is CTG.
Ah,
Myotonic dystrophy, cataract, 2P. 2P means frontal balding and
yes,
gonadal atrophy.
CTG, cataract, pupil. I'm gonna keep repeating, asking you that till we
No,
pick.
no, it is good. It is
Because it's just one of
trinucleated. This is the way of learning. Like if you asking things again and again, it 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 helps both of us.
yeah, I
Like
know it's a weakness of mine. I just cannot memorize those
so,
trinuclear things.
don't just hide your weakness because I am nobody.
CTG, cataract, pupil, and hypogonadism.
In the exam, we actually fall in the same trap what we fall
Yeah.
while doing what we. Okay.
I took the two surgery, like the two surgery CMS, and I actually finished with like 10 minutes left, the
Okay.
surgery thing. I was like so impressed. So now I'm not thinking too much. I'm just going to just pick. That's what I was doing. I was like, I didn't even put the timer that I thought. I was like, I have to try to get, just move, keep moving, keep moving. And I did it twice and I finished with like 10 minutes. I was like, okay, okay. So now I'm just not overthinking, which sometimes is good, but sometimes it's like you don't even give time to think. You may have found the right answer, but you just pick really quick to move on, so it doesn't help. But yeah,
If you are confident, like some answer, like in this question, I need not to exclude the other options because I am very
yeah,
confident in
yeah,
that it is MJ. So I try my way is trying to establish the thing from the stem. That's
yeah,
why I sometimes I fall in the trap, like not excluding everything. You got my point.
yeah. No,
Uh,
definitely. If you can get it from the stem, I don't think you should do the excluding thing. You should just pick the answer and move on.
yes,
Like,
but these tricks sometimes does not. These tricks sometimes make me Get wrong answer. Okay. I should exclude, but there is not enough time, so I need to find out answer very quickly.
Very quickly. No, I know I'm trying to work on it because I know this is going to be, and if all the comments I'm reading already, it's like, guys, work on your timing, work on your, because the questions are not that hard, but they are long. And the time, work on your timing, guys. Work it. So I'm like, yeah, I know this is going to be my issue.
In the like in the amboss there
What?
is there is something called attendance tip, and there is something called like they have highlighted something like in
Mm-hmm.
the question stem there is 1 to 2 line you need to see.
Mm-hmm.
So these things is highlighted by the emboss, so that can help you while you are solving.
Mm-hmm.
Okay. We need to finish the CMS form first,
Oh my God.
then
Yeah.
we should jump onto the emboss.
Yeah.
Okay.
No, once we finish CMS, we need to do the free 120. We
Yes, yes,
haven't,
yes.
you know.
We need to solve the free 120 also. Yes. Then we need to jump on the emboss. Okay.
No, but we haven't finished the MBME 14.
Okay, okay, yes. I haven't given that. Okay, I haven't solved.
We have a lot of things to solve.
Yes.
Mhm.
These things we need to solve first. Yes. Okay. A 70 year, a 70 year. I don't know how people give exam within 1 to 2 months.
I
Are
don't. I swear, I don't. I
are
don't. No,
are there machine or or
no, no.
are we
There
dumb?
is some. There is one guy that explained it, and I guess he got a super high score, like 270 something. But he was like, "I'm not gonna come and bullshit and be like, oh, I had a 2 week dedicated period. This is not true." Like, these are those A students. So he started doing CMSing. He was in clinical. He finished UR the first time he think he was in clinical. So he has done everything he was in clinical already.
When he was in the like in the school,
Rotations.
medical
Yeah, when
school.
he was doing rotations. So he has done
Okay.
all of it. Like he had done UR twice already when he
Okay.
was in rotations. He has done all the CMS. He has done, so he was like during his dedicated period, he actually didn't have anything to do because he had already done like most of everything.
And
And
in your like in the US medical system, like what is the exam or like how you give exam? Like what is the way of giving exam? Like this type of NBME, like you how you give exam?
what
In
do you
our
mean?
country, like exam is so boring. Like we have to write 3 hours and then we have to give. What type of exam happens in your country in the medical school? I'm talking about the medical school. You got
Oh, oh, when you are in class, the when you still not the rotation part,
no,
the
no, not the
part
rotation in the medical school.
um, yes, there are. Mine was like almost every 2 weeks we had exams,
The
and then
exam is like what type of exam? Like quiz exam
like
or
quiz exam,
okay.
depending on the class. Like anatomy, we had like every 2 weeks quiz exam. But I don't think those were MBMEs because they weren't. I don't think they were that long. I think it's the professor himself that makes the exam, the actual professor.
Is it
And then
like a single base like what we are doing now, or it is written question? That's the
no, no,
thing I want to.
all of it is like this. It's multiple choice. Is that what you're asking? If it's
Yes, yes.
multiple choice, like yeah, yeah, all our exams are multiple choice. We don't do written ones.
Oh,
So yeah, and then at the end of like anatomy, at the end of the semester, then you have a big one, kind of like an MBME, kind of big. And then
so you are accustomed with this type of questions previously,
yeah, yeah, like multiple choice like that they give you A, B, C, D. Yeah, that's all that
but
we do.
our exam pattern is quite different. You have to write an essay
Oh,
you have to
I
write
remember.
about SIA age. So you have
Okay.
to write everything, like the whole
I
box
remember. Yeah,
of the
yeah, I remember.
SIADH. So
Though,
it
yeah,
is very tough to remember.
yeah. I remember those ones. I used to do those. Was it in high school or whatever? I used to do those ones,
In
and then
in our medical school, our exam is not that kind. So when I start solving the questions, so I get
Mhm.
frustrated.
Oh, okay. No, but us is like this. So yeah, the guy was like, he's already done all of this. He's already done like during his study time, he was doing ambos because he already done UWOT 2 times. So he was doing ambos, and then he ran out of. He finished ambos. He didn't know what to do. He started. He did all the MBMEs. He was scoring like 270 something in the MBME. It was like so. He was like, of course you're gonna get
He was
270.
ready at the time of his rotation.
Exactly. Like he was ready by the time he even finished rotation. He could have taken the exam right because he already did everything. He only needed to do the MBMEs. So he started just trying to find more things to do during his dedicated period, like Randy, whatever, Nell, and all these things because he had already done everything the normal. So yeah, so he was like, don't follow these people that say that we only did 1 month of dedicated or 4 weeks or whatever. They're not lying, but it's like they don't count the things that they did when they were in rotation and all that so yeah, but I think this is where I missed because I didn't know all these things during my rotations. I was just going to the rotation chilling and going to rotation going home and yeah, but it's okay,
Yes,
it's okay.
no problem.
Yeah,
Okay,
I
a
guess so.
70-year-old man, a 70-year-old man comes to the office because of 3-month history of progressive swelling. 3-month history of progressive swelling that began in his legs and now extend to the lower abdomen. He also he also has noted fatigue and shortness of breath during this time. He says he lost consciousness briefly while mowing the lawn. The patient experienced the patient experienced an episode of chest pain 1 year ago and a coronary angiography at the time disclosed no coronary artery stenosis. He has 12-year history of severe obstructive sleep hypoapnea, and has been unable to tolerate continuous positive ERA pressure. He has a 5-year history of hypertension, well controlled with hydrochlorothiazide and verapamil. He does not smoke cigarettes. He drinks 2 12 ounce beer weekly. He is 5 feet 11 inch tall, weight 104 kg, BMI 32 kg per meter square, temperature 37, pulse 80 per minute, respiration 18 per minute, blood pressure 128/82. Examination of the skin over the lower extremity shows pinkish discoloration. There is edema of the lower abdomen. There is edema of the lower abdomen and the lower extremities. Bilateral cardiopulmonary examination discloses regular heart rate and rhythm. Jugular venous pressure is 8 centimeter above the sternal notch or clavicle. Which of the following is the most likely cause of this patient's symptoms?
Jeez, the hell. COPD, edema, and he smokes. No, he does not smoke. DVT, sorry, left-sided heart failure, regular rate and rhythm now. Pulmonary hypertension. Mm, he has Obstructive sleep apnea. I guess that's promising. That makes sense. Skin discoloration. Hmm.
OSA, he has the history of OSA.
Yeah, I
So
think
OSA
it,
can cause pulmonary hypertension, isn't it?
I think
And
so. Yeah.
JVT is raised.
Yeah.
Features of right heart failure. And another thing, there is edema on the legs. So
Mm.
features of the right heart failure, features of the right heart failure. And OSA is the risk factor. Okay. I'm thinking about pulmonary hypertension.
Okay, let's see. You are right. Pulmonary hypertension, one of the cause of right heart failure in patients with no evidence of left heart failure. Signs suggestive of right heart failure include bilateral lower extremity edema, JVT, hepatosplenomegaly, abdominal swelling. There are multiple causes of pulmonary hypertension, including genetic causes, connective tissue disease like lupus, HIV, congenital heart disease, left-sided heart failure, COPD, chronic embolism, pulmonary hypertension, and OSA. Transthoracic echo may be used as initial screening um, test for evaluation and may suggest diagnosis. Further studies include high-resolution CT scan, ventilation perfusion, lung scans, right and left heart catheterization, lab studies, polysomnography. Once the underlying cause of pulmonary hypertension has been identified, treatment aimed at symptomatic relief, including diuretics, may be used along with treatment for underlying cause, as CPAP for OSA. For this patient, the most likely cause of pulmonary is poorly controlled OSA. It's not COPD, obstructive of the associated with tobacco use caused by respiratory airflow obstruction. Chronic symptoms are improved with the use of inhaled long-acting beta agonists, inhaled muscarinic antagonists, and steroids. Called COPD may be caused by pulmonary. COPD may cause pulmonary hypertension and right heart failure in patients with that smoke. DVT may cause lower extremity pain. This don't make sense. It won't cause the JVD. Wait, no, wait. May cause lower extremity swelling, pain, and discoloration. Symptoms may be acute in nature, and patients are treated with anticoagulant and thrombectomy depending on the lab. This patient clinical presentation is not consistent with the DVT. Okay, next.
A previously healthy 32-year-old a previously healthy 32-year-old man 32-year-old woman comes to the office because of 3-month history of lip smacking, finger fumbling, lip smacking, finger fumbling, and alteration of the consciousness during which she feels spaced out. Each episode lasts 30 to 50 seconds. The episodes initially occurred once every 2 weeks, but recently have been occurring twice daily. The patient is not aware of her symptoms while she is experiencing an episode, but has been told about them by friends and family members. She says she feels tired about after the episodes. She feels tired after the episodes and has noticed mild memory loss and difficulty with word finding since their onset. She takes no medication. She is 5 feet 6 inch tall, weight is 62 kg, BMI is 22 kg per meter square. Her temperature is 36, pulse 88, respiration 16 per minute, blood pressure 124 by 82. Physical examination including neurological examination shows no abnormality. An EEG is obtained shows epileptiform discharge. Which of the following is the most appropriate next step? Yes.
Is it MRI or is it urine toxicology? She's 32. Hmm.
What is your diagnosis?
I thought just epilepsy and, yeah, just epilepsy. But then she's 32. So are we thinking that maybe she's taking something and that's why she's having the
Can be.
okay, maybe. we are overthinking. Okay, let's just go with epilepsy. I think we can overthink. Let's just go with, yeah, let's just go with epilepsy. It's okay. Okay. Ready?
Yes.
Okay, yeah. It's MRI of the brain. Then we will try and overthink. Focal onset impaired awareness seizure. Focal onset impaired awareness seizure. Oh, Jesus. Also called complex partial seizures. As this name suggests, the seizure affects a specific or focal region of the brain and therefore produce motor or sensory symptoms that are localized to one or a few areas of the body. Patients will be unresponsive during the seizure, impaired awareness, focal impaired awareness. Okay. Oral and manual automatism, as in this patient, are suggestive of temporal lobe lesion. The most common origin of the seizure, upper limb dystonia and autonomic disturbance such as epigastric rising sensation can also occur in temporal lobe seizures. Patients may experience visual, auditory, and sensory auras preceding the seizure. Focal onset impaired awareness seizures are often accompanied by a brief posictal marked by confusion and fatigue. This seizure will demonstrate localized rhythmic activity by generalized slowing of EEG. The lesion most commonly responsible for temporal lobe epilepsy is mesial temporal sclerosis, also called hippocampal sclerosis. However, new presentation with progressive worsening frequency and cognitive changes should raise concern that the cause may be a tumor. MRI of the brain should be ordered to search for a mass lesion. If located, surgical excision can be done. It's not during toxicology screening is useful in the workup of suspected substance use or toxin-related seizures cause include like stimulants like cocaine, amphetamine, ecstasy, PCP, theophylline, toxins such as trichosis. I don't know how to say that name. Seizures tend to be generalized, not focal. A chronic progressive presentation is more consistent with the structural lesion. Okay, next.
So if in the if any epilepsy comes with like confusion altered, it happens in the temporal lobe. Temporal lobe epilepsy usually comes with this type of lip smacking, alteration of the consciousness, or any epilepsy can happen anywhere in the brain.
Epilepsy can happen anywhere. They're just saying that commonly it usually starts in the
Temporal
temporal
lobe.
lobe, but it can happen anywhere. Remember, we found one that started in the parietal lobe or something. But they're saying that usually it's temporal lobe, and then things that will guide you toward temporal lobe will be the lip smacking, the smell issues, like I smell something before the epilepsy, or like the yeah, I guess things like that, or the stomach that you feel a rising in your stomach, things like that guide you to that it's epilepsy, it's a temporal. It starts in the temporal lobe, but it can
Oh,
start anywhere.
okay. A 21-year-old man comes to the clinic because of 3-month history of increasingly severe headache. 3-month history of increasingly severe headache. Initially, the headache were only present on walking in the morning, and he rated the pain 3 on a 10-point scale. However, the headache are now constant, and he rates the pain as he rates the pain as 7 out of 10, a point scale. The headache increases in intensity when he is lying and becoming less intense when he is sitting. The headache is initially relieved by ibuprofen, but he reports that ibuprofen has not effective for the past 3 weeks. During the past month, he has also had fatigue, cold intolerance, erectile dysfunction, and a 3 kg unintentional weight gain. He has experienced any visual scintillations, scintillations and nausea and emesis. He was diagnosed with delayed puberty at age 17 years. His mother has hypothyroidism. The patient appears to be in moderate distress. He is 175 centimeter, 5 feet 9 inch tall, weight is 122 kg, BMI 40. Temperature is 36, pulse 78, respiration 16, blood pressure 154 by 92. Physical examination shows dry skin and mild gynecomastia. Confrontation of the visual field testing shows bitemporal inferior quadrant defects, bitemporal inferior quadrant defects, sexual maturity. Rating is 3 for genital and pubic hair development. CT scan of the head show ventriculomegaly and calcified cystic structure. On the hypothalamus, which of the following is the most likely diagnosis?
Jeez. Mm,
Hypothalamus. Calcified cystic structure.
okay. Ready?
1 minute. Okay.
Okay. Ah, scanopharyngioma. Solid, slow-growing benign tumor that arise in the from the Radke patch during embryology development. This tumor may be intracellular or supracellular, though they are often supracellular. Approximately half or are diagnosed by age 20. Symptoms caused by mass effect include abnormal vision, bitemporal hemianopsia, decreased growth, signs of hypopituitarism, and diabetes insipidus. This tumor may show calcification on imaging, unlike pituitary adenoma. Okay. Patients with craniopharyngioma and associated syndrome should be evaluated for possible surgical resection. It's not D. Optic chiasm glioma is a slow-growing tumor involving the optic nerve. These rare tumors commonly affect children and patients with neurofibromatosis. An optic glioma will affect the visual field of the affected eyes only. Additional endocrine and neurologic symptoms would not be expected. Optic chiasm. Okay. Pituitary adenoma, the most common neoplasm identified in the pituitary gland. It may secrete hormones such as prolactin or growth hormone or whatever, causing symptoms of hyperpituitarism. The pituitary gland rests on the bony cella turcica, just inferior to the optic chiasm, which is vulnerable for uh, which is vulnerable to compression by pituitary mass lesion. The resultant visual field deficit is commonly bitemporal hemianopsia, findings suggestive of a pituitary mass. Okay.
So calcified uh, mass in the cellular region should be craniopharyngioma.
Calcified mass in the cellular region that causes hypopituitarism here should be craniopharyngioma. It seems like pituitary adenomas mostly cause hyperpituitarism and bitemporal hemianopsia.
And this and in the this craniopharyngioma there is pituitary stalk compression that leads to panhypopituitarism. That's why there is this patient has growth failure, delayed puberty, isn't it?
Mm-hmm.
So it may be due to pituitary stalk compression. There is no visual field problem, isn't it?
He
Usually,
does. He has. Oh, you mean the patient has a inferior quadrant defect, by temporal inferior quadrant defect?
that was clue to
Oh,
bitemporal hemianopia.
no, by temporal inferior quadrant defect. Just the quadrantopia, I'm thinking.
Bitemporal, okay. Bitemporal quadrantopia. Okay, quite difficult.
Yeah, but I was between. I knew it was something to do with the pituitary, but I couldn't figure out
Craniopharynx.
craniopharyngioma or
Yes. So
pituitary.
what you have picked? Pituitary adenoma.
Yeah, but I guess
Mm,
the key was the calcified stuff.
calcified. Yes.
Yeah, that was the key.
And in the pituitary adenoma, what type of feature found in the MRI or CT scan?
I think that's what they're saying, that the pituitary adenoma, you see hyper, like everything will be high, and then you'll see the bitemporal hemianopsia. I don't know what features on the MRI, but
Okay.
yeah, yeah,
A 30 a 37-year-old woman. A 37. This eighth one is hard. Okay.
yeah, it's really hard. It
A
is.
37-year-old woman is brought to the emergency department because of cough, fever, myalgia, and generalized headache. Cough, fever, myalgia, and generalized headache, vomiting, and arching neck and back for 36 arching neck and back for 36 hours. On arrival, she is having generalized tonic-clonic seizure. She has two daughters, aged 12 and 15 years. Her temperature is 37 degrees Celsius, pulse 120 per minute. Regular respirations are 20 per minute. Blood pressure 120 by 78. The there is purpuric there is purpuric rash over the lower extremities and the persistent lateral gauge. Examination of the CSF show 200 segmented neutrophil, 200 segmented neutrophils and 2 erythrocyte per millimeter cube. Glucose concentration 40. Gram stain show gram-negative diplococci. Which of the following is the most appropriate treatment to prevent this condition?
Ready?
Oh, prevent. Okay. Yes, yes. Rifampin rifle.
Yeah. Patient has finding consistent with acute meningococcal meningitis, including fever, headache, neck stiffness, purpuric rash. Meningococcal meningitis caused by infection with Neisseria meningitis, the most common cause. Bacterial meningitis in teenagers and adults. Cluster infection may be seen among young adults sharing living in college dormitories of military barracks. The CSF analysis of bacteria shows increased leukocyte with neutrophil predominance, increased protein, and decreased glucose. Appearance of the fluid is cloudy, and additional studies. Yeah, gram-stain and bacterial culture will be positive. Meningococcal meningitis can be life-threatening. Therefore, treatment with IV antibiotics should be started as soon as possible. If possible, blood culture should be obtained before antibiotics are started, but treatment should not be delayed while waiting for the lumbar culture to be performed. Ceftriaxone is the preferred initial antibiotic. Those in close contact with the infected individual should receive prophylactic treatment with rifampin, ciprofloxacin, or ceftriaxone. Next.
Okay, next. Gain the MRI.
What are we looking at? Is it like, what is it?
Spinal
The
MRI.
Oh, spinal. Okay. I was like, what the hell is this? Okay. Okay.
Okay, let's read first.
Yeah.
Okay, a 45-year-old man is admitted to the hospital because of 9-day history of increasingly severe low back pain. 9-day history of increasingly severe low back pain. The patient says he has experienced intermittent low back pain during the past several hours. Sorry, during the past several years, but it has never been as severe as his current pain. He rates the pain 8 on a 10-point scale. He says the pain is constant and localized to the lower back. It has not radiated and is worsened any type of movement that involves bending. He has not had any recent trauma or falls and has not had incontinence or paresthesia in the legs. He has a history of illicit drugs, including IV cocaine twice weekly during the past 4 months. Temperature is 37 degrees Celsius, 37, pulse 90, respiration 12 per minute, blood pressure 130/80. Mm, A physical examination show localized tenderness in the lumbar area. There are multiple track marks over the upper extremities bilaterally. Results of a complete bilateral count and a basic metabolic panel are within reference ranges. ESR is 85 millimeter mercury. Serum C-reactive protein is 95. Urine toxicology screening is for cocaine metabolites. MRI of the lumbar spine is shown. Which of the following is the most appropriate next step in the management of these current symptoms?
Hmm. Don't know. Do we do steroid or do we do IV antibiotic?
If I just think simply, the last question of the NBM is 7. There is like if there is acute low back pain, we will give oral steroid first, isn't it?
Okay.
Or sorry, oral steroid, oral ibuprofen.
Oh, you think it's NSAID?
No, 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 no.
Oh,
Wait. But if as this patient has done MRI within the 9 days, so pain is severe. It is not like acute, normal acute low back pain because the pain rate is very high, isn't it?
okay.
So I think that we should go one step ahead.
Okay.
But there is no urinary incontinence or paresthesia.
But he's an IV drug user and he's had the pain more than 4 weeks. So it's started for, so it cannot be physical or NSAID.
Yes, I think
It
that
has to
I
be,
think that steroid or laminectomy may be the answer.
oh no, I don't think it's laminectomy. I think it has to do with the ESR is high. So it's some kind of inflammation.
So
I
you
don't
want
think
to
it
give steroid.
Yeah, I was between steroid or antibiotic, but I don't think it's antibiotic, right? Because it
Antibiotic, why?
because okay, okay.
Antibiotic for like if it is infective endocarditis, isn't it?
Yeah, okay.
There is
So
no
no,
fever and there is no murmur.
okay. There is steroid probably. Okay, ready. It's oh my god,
What?
it's antibiotic. This CMS, I feel like I'm going to miss everything. What is the explanation? It's okay.
Is it
I guess the
infect? Oh,
huh?
it is discitis.
The what? I guess anyway.
Like the 7 question make me headache.
Oh
Trust
god.
me, I never faced such struggle in doing CMS.
IV antibiotic therapy is used for treatment of infection of the intervertebral disc, but she doesn't have fever. I guess
Yes, he
also
does.
known
She
as
does not have fever.
I guess the key was the ESR and CRP were high. Okay. Infection may occur from hematogenous spread, as in this case of IV drug use, whatever, direct inoculation from surgery or trauma, and spread from overlying soft tissue infection. Most common pathogens, Staph aureus, and symptoms may include local tenderness, symptoms such as fever, chills, and symptoms and signs including neurological deficits. Lab studies may show leukocytosis and increased inflammatory markers. Diagnosis is confirmed by MRI. Treatment includes surgical debridement with intraoperative cultures to confirm and antibiotics target to the common and most likely organism. Epidural administration of steroids is contraindicated in patients with discitis. Epidural steroids are used in the treatment of inflammatory and compressive processes, including disc herniation. Okay, so I don't know what is the inflammation of the disc. They're showing it somewhere here. I don't know, but I guess, yeah.
He has highlighted in here in the this material. I don't
Yeah,
understand actually.
I would have, I don't, yeah, I wouldn't have understood that. I guess the key, he's doing IV drug
Drug
use, so
user. And
so it
yes,
went
our CRP is high.
high. Okay, fine. This is a really tough CMS. Okay, next.
You want to take break?
Yeah, sure.
Because my brain is actually not working.
Yeah, I don't ready.
Yes. A 77-year-old woman, a 77-year-old woman is brought to the office by by her daughter because of 1 year history of gradually increasing memory problems. 1 year ago, the patient began having difficulty keeping track of her appointments and social schedule. 6 months ago, she noticed difficulty remembering names of a new acquaintance and the details of conversations with her friends and the family. 1 month ago, her daughter noticed that the patient was unable to remember recent remember recent family events. The patient is still able to care safely for her grandchildren, to perform household chores and maintenance, and to manage her finances. She has no other history of serious illness, takes no medication, vital signs are within normal limits. Physical examination include neurological examination shows no abnormality. On mental status examination, she is alert, cooperative, and oriented to person. When he asked when asked questions regarding orientation to place and the time, she does not remember the name of the clinic and provides the incorrect months and the day. She is able to repeat three items immediately after hearing them. She recalls one of them after 5 minutes. Which of the following is the most likely location of this patient's dysfunction?
Ready?
Yes.
Is hippocampus. Jesus. Mild cognitive impairment is used to describe patients with the presence of memory deficits and cognitive dysfunctions, but without substantial enough symptoms to warrant diagnosis of dementia. MCI, mild cognitive impairment, is common in patients over 70 and is the early clinical manifestation of neurodegenerative disease. Patients may experience symptoms including poor memory, poor sleep, poor mood changes. MCI is associated with the position of amyloid plaques and tau tangles in the hippocampus, which may be seen in Alzheimer's disease. Diagnosis involves a comprehensive neuropsych testing. A subset of patients with MCI will progress to Alzheimer's. It's not caudate nucleus, it's component of the patient ganglia. The caudate nucleus plays a role in movement and has been implicated in both Parkinson and Huntington. It is not Nucleus accumbens is associated with rewards, reinforcement, and motivation. Nucleus accumbens has been associated with addiction. Okay, next.
Yes, a 24 a 24-year-old woman, sorry, a 24-year-old man is a type with a type 1 diabetes mellitus comes to the physician because of 3-week history of fever, back pain and night sweat. During this period, he has required increasing doses of insulin to control blood pressure concentration. He appears flushed and diaphoretic and is in acute distress. His temperature is 103, pulse 130 per minute, respiration 35, blood pressure 100 by 60. Examination shows severe tenderness in over the mid spine at T10. His fingers stick. Blood glucose concentration is 200. Which of the following is the most likely diagnosis?
Ready?
Yes.
With bacterial abscess of the spine. This patient presents with fever, back pain, point tenderness at T10, which is suggestive of spinal epidural abscess. Epidural abscess is a localized collection of pus in the epidural space. Yeah. Most commonly occurs in the spine, but may occur in the brain. Most patients are elderly and have a history of concomitant infection and often have a history of immunocompromised like HIV, diabetes, alcohol use disorder. Epidural abscess is common in patients with a history of heavy drug use. Infectious organisms usually spread to the epidural space hematogenously from spinal surgery or from osteomyelitis. Staph aureus frequently causative organism, but fungal infections may also occur. Patients present with signs and symptoms of fever, altered mental status, meningitis, localized back pain, tenderness to palpation, numbness, paralysis below the affected spinal nerve. Treatment is with broad spectrum antibiotics and surgical drainage of the abscess. It's not tuberculous abscess of the spinal cord disease presents with stigmata of chronic tuberculosis along with subacute to chronic back pain, fever, chills, and neurologic deficit. X-rays, if relieving of disease, will show evidence of osteomyelitis, lytic or reactive bone lesion. This patient has no history of primary TB, nor does he have significant risk factors aside for diabetes. Mhm. Next.
Okay. A 16-year-old boy is brought to the 16-year-old boy is brought to the clinic by his mother because of 1 week because of 8 week because of 8 week history of because of 8 week history of lump on her left wrist. Lump on her left wrist. The patient first noticed the lump he began taking the lump when he began taking a computer programming class in the school. He says the lump keeps getting sore, but because he rests on the keyboard during class, the lump was minimally increased in size since the first noticed. The patient underwent above knee amputation of the left femur 8 years ago. After being diagnosed with Ewing sarcoma, he wears prosthesis, and his only medication is gabapentin for phantom limb pain. His father and his parents' grandmother has hypercholesterolemia. Patient appears comfortable, vitals and normal. Physical examination show firm, smooth, rounded 9 millimeter mass over the ventral radial aspect of the left wrist. The mass is mildly tender to palpation and trans illuminates. The amputation site of the left femur is erythematous at the site of articulation within the processes. Which of the following studies is indicated at this time? Is it ganglion?
It must be some kind of cyst because it's transluminate. So I don't know if we aspirate it or we just don't do anything.
I think that we should not do anything. Only 6 years old, 16 years old.
Okay. Ready. So, ready?
Yes, yes.
So, no diagnostic studies necessary. Ganglion cysts are fluid-filled swellings to align a joint or a tendon sheet. They are most common soft tissue growths. They are the most common soft tissue growths of the hand. On exam, they are smooth, maybe tender to palpation, and transilluminate. Ganglion cysts are most often diagnosed based on physical exam findings. Although ultrasound may be used in case of uncertainty, patient can be managed with reassurance, although patients with refractory syndrome may have the cystic size. It's not fine neither aspiration of the mass will show or the mass will show no specific finding for gangliosis and poses the risk for infection and recurrence. Fine needle aspiration is used in the diagnosis of many lesions, thyroid nodules, but does not have recognized role in clinical diagnosis of a gangliosis. Okay, next.
An 8-month-old boy is brought to the physician by his parents because they are concerned that he is becoming weak. He had previously fed well, but over the past 2 weeks, he takes no longer to drink his bottle and chokes intermittently. Although he was able to four, roll over at 4 months, he has not developed the ability to sit. Over the past month, he has stopped rolling over. He appears alert, visually interactive, he smiles and coos. His gag reflex is depressed and the tongue his gag reflex is depressed and the tongue while at rest and has constant movement on the surface. Muscle tone and strength are diffusely decreased. Deep tendon reflex are absent throughout. Which of the following is the most likely location of this patient's abnormality?
Hmm.
Should we think like lower motor neuron?
Yeah, I think that's the only thing I mean, yeah, lower motor neuron, but I'm like with the tongue and the gag reflex, I guess. I guess. I'm between the anterior horn and the myoneural junction, my muscle and neuron, muscle and neuron. Myoneural junction will be, yeah, it will be like myasthenia gravis and all that.
8 months old baby myasthenia gravis, isn't it atypical?
Yeah, it's very atypical. So it should be anterior horn. But what would it be? What is it? I, I don't know. What disease does a 8 month old gonna have?
Uh, is there like botulinum, this type of thing? But no
Oh,
things.
okay. So yeah, I guess botulinum
Or
is at the
look, he takes longer to drink his bottle and chokes. Sorry,
yeah, it can be botulinum, but botulinum affects the anterior horn.
botulinum isn't it the lower motor neuron? Tetanus
Yeah.
is the upper motor neuron. Tetanus spasm, spastic
Oh,
paralysis,
oh,
botulinum, floppy baby, anterior horn, isn't it?
oh.
I am
I
just
don't know.
guessing. I am just roaming around here and there
I,
because
I don't.
I don't get any definitive clue. That's why I am
Yeah,
just asking.
yeah, yeah. Let's say we're going with botulinum. I mean, that's the only thing that makes sense because it's a baby.
Yes,
Um, I,
because
I
other myasthenia very atypical. I don't know. Maybe may
yeah, it will
happen.
be too atypical. So it's botulinum. So we know it's floppy babies. So
Yes,
I guess it's
lo-
anterior horn
horn cell,
instead of.
isn't it?
Oh, okay. Let's check. Yes, anterior horn, but it was not botulinum. But I mean, at least yeah, it's anterior horn.
Okay,
Spinal
we
muscle.
are close.
Yeah, I mean, at least we could come up with something.
It will
Uh,
not gonna come in the exam. Spinal muscular atrophy is very high
yeah,
yield.
yeah, that's too much. Spinal muscular atrophy is a group of autosomal recessive disorder that lead to degeneration of motor neurons and result in progressive hypotonia and hyreflexia. So I guess degeneration of the anterior horn, whatever.
Yes,
Wernicke-Hoffmann spinal muscular atrophy is the most common subtype and considered the most severe, with infants experiencing the onset within like the first 6 months of life. It is characterized by hypotonia, diffuse weakness, delays, and absence of motor development. Notably, higher CNS and cerebral function remains intact. Spinal muscular atrophy in general is a type of lower motor neuron disease that affects the anterior horns of the spinal cord. Degeneration of these cells results in loss of innervation to the muscle. In infants, parents may observe difficulties with feeding, swallowing, respiratory function. Deep tendon reflexes are absent, and tongue fasciculation are common. Infants often fail to develop head control, and ability to sit up, crawl, and stand. Hypotonia and reflection may be present at birth or develop shortly after with progression in previous muscle training and tone. Treatment is supportive. Prognosis is poor, with few patients surviving past 2 years of life. It is not brainstem lesions tend to present with cranial nerve deficits, encephalopathy, contralateral and bilateral motor and sensory deficit from the eruption of and afferent tracts. Motor deficits will follow an opermotor neuron disease pattern with hyperreflecture and clonus. It's not myoneural junction disorder may present with muscle weakness, particularly fatigable weakness, which worsens the more the muscle is used, so like myasthenia gravis. Okay, next.
okay. To a 25-year-old man comes to the emergency department 30 minutes after an apparent seizure at work. She was talking to her boyfriend on the telephone when she suddenly fell off to the floor unconscious and started shaking all over. She has no bladder and bowel incontinence. She has no history of head trauma, febrile seizure during childhood. She has had headache over past 4 months and went to the physician because she was concerned that he had a brain tumor. Neurologic examination of her brain EEG showed normal findings. She states that her boyfriend recently told her she wants to end this relationship. Which of the following is most likely this conversion?
Hmm.
It is conversion, isn't it?
That's what we thought last time. It ended up being somatization.
But okay, let's see. I am still
Let's
conversion.
go with conversion. Okay, let's see. Is conversion disorder, also known as functional neurologic symptom disorder, involves neurologic symptoms such as sensory motor dysfunction that are not fully explained by objective findings on physical exam or imaging. Patient presents with an episode of generalized shaking with lack of incontinence, negative EEG, Lily has psychogenic non-epileptic seizure, a form of conversion disorder. Functional neurologic symptom disorder is postulated to represent a subconscious conversion of intolerable emotional distress into physical symptoms. Side comorbidities such as depression are common but not present in all patients. Physicians should conduct a thorough history and physical exam and obtain lab imaging, blah, blah, blah. Treatment of conversion involves education about the diagnosis, physical therapy, and CBT. It's not a somatization of somatic symptom disorder characterized by excessive preoccupation with one or more somatic symptoms. Patients persistently devote excessive time and energy to these symptoms or related health concerns, like repeatedly going to the doctor. This patient does not demonstrate evidence of excessive healthcare seeking behavior and is not preoccupied with ongoing somatic symptoms.
So how we can differentiate these two based on this question?
Well, it
You
says
picked
that she didn't.
somatization, isn't it?
Yeah.
Okay, I picked conversion, but I am still confused.
Oh no, sorry, I picked conversion.
Okay,
But um, yeah, they're saying that based on the explanation here, they're saying that she didn't go to the doctor again and again and again based on the symptoms that she was having, the headaches and all these things. She says she went for the headaches like 4 months ago. That's it. That's when she went. She didn't go back again.
but she was
Uh,
concerned that she had brain tumors.
yeah, but she only went once. For somatization, she will have to keep going. The doctor says, no, you're fine. And she keeps going and she keeps going. And the doctor keeps saying, you're fine. But she just went once. The doctor said, no, you don't have anything. And that's it. She left it.
She's convinced. Okay.
She's convinced. And she's not worried. It doesn't say nowhere that she's worried about her headaches or anything or her, you know. And then what else? Conversion. I guess she had an epileptic attack, but she didn't have no bowel or bladder
It
incontinence.
is not epileptic attack.
Yeah, it's not.
Because
So it's not really an epileptic attack.
she is faking as because her boyfriend is going to leave her.
Mm-hmm.
That's because sometimes when the epileptic attacks or seizure happens, there may be like urinary incontinence, there may be bowel movement, and sometimes tongue biting should be found.
Mm-hmm.
Okay, let's go to next question. A 57-year old woman comes to the physician because of 3-month history of hearing loss, ringing, and feeling of fullness in her left ear. Feeling of fullness in her left ear. She has had recurrent episodes of vertigo during this time. She has 20-year history of migraines. She has a myocardial infarction at the age of 54 years and a cerebral infarction at the age of 55 years. She was diagnosed with colon cancer 10 years ago. She was successfully treated with colon resection. Medications are propranolol and 81 milligram aspirin. She says that her father had similar rare symptoms. Her temperature is 37 degrees Celsius, pulse 86 per minute, respiration 12 per minute, blood pressure 135 by 76. On examination, ocular movements are full and there is no nystagmus. Weber testing localizes to the Weber testing localizes to the right. Hearing is decreased. Hearing is decreased in the left ear compared with the right. Which of the following is the most appropriate treatment? Hearing is decreased in the left. Part.
Really?
1 second. Is it sensory neural hearing loss? Weber localizes to the right.
Shit, I'm never able to know to understand that Weber thing.
Is it Meniere's disease?
Meniere's is the one where there is high endolin. Is it
Yes.
that one?
He-
I
Uh,
mean,
ringing ear.
that's what I thought, but I don't know the medication for that.
Okay, I think. Okay, let's see. Oh, if it is Meniere's,
So it's
A. Sorry.
no, no, it's thiazide therapy. Um, hydrochlorothiazide therapy is used in the treatment of Meniere disease. Meniere is a condition of vestibular dysfunction and sensorineural hearing loss that results from pressure accumulation in the endolymph of the inner ear, including the otolic organs, semicircular canal, and cochlea. The classic triad of symptoms is episodic vertigo, hearing loss, tinnitus. The diagnosis is based on clinical symptoms and audiometric evidence of sensorineural hearing loss. Diagnosis may be supported by results in the Weber and Rhine test, in which bone conduction assesses the sensorineural hearing and air conduction assesses the conductive hearing. Vestibular testing may be normal or show unilateral peripheral vestibular dysfunction. As the disease progresses, management includes lifestyle modification like avoiding salt, nicotine, alcohol, and stress, and medications for episodic vertigo as well as diuretics, um, including thiazide. It is not what's between C and E. Scopolamine is used in treatment of motion sickness and in the treatment of nausea and vomiting. Like diphenhydramine, adverse effects include mydriasis and dry mouth. Diphenhydramine is used for seasonal allergy in causes anticholinergic side effects. It's an antihistamine that also binds to several receptors. Anticholinergic effects, flushing, mydriasis, dry mucous membrane, and cell metastatic urinary retention. Okay.
Very atypical. The treatment of the Meniere is thiazide.
So it's,
Are you getting lost?
I am lost on this CMS. I'm really lost.
If this CMS comes
Yeah,
Uh,
it's like,
if this CMS comes at the very first block of our exam, what will happen?
see,
So, actually it based on person to person.
yep.
Because I don't think that this CMS is doable actually.
I really don't. I mean,
Like if this type of CMS comes at the very first or second block, he will broke
well,
because your guessing is not reaching the options.
yeah, it's not, even if I guess on this one, it's still like, yeah.
Okay. An 11-year-old boy with hemophilia A is brought to the physician because of headache and decreasing school performance since falling 10 feet, uh, 10 feet to the ground 2 weeks ago. Because of headache and decreasing school performance since falling 10 feet to the ground 2 weeks ago, he did not lose consciousness at that time and remembers striking his head. CT scan of the head obtained in the emergency department uh, uh, on the day of the fall showed no abnormality. Current examination shows bilateral papilledema and hyperreflexia on the left. Vital signs are within normal limit. Which of the following is the most likely diagnosis? You said something like, is it subdural?
That's what I'm thinking, because the other
You
one
said
sounds.
yesterday like subdural to happen, like what is that? Like fall or trauma, something like I totally forgot.
I totally forgot to.
But you said something about this epidural subdural.
Mm,
Okay, let's see.
let's
It
see.
is not post concussion because post concussion it can be post concussion, but post concussion does not come with bilateral papillary edema and
Yeah,
hyperreflection.
yeah. Let's
If
see. So,
there is no symptom, then it is post concussion.
yeah, it's subdural hematoma. We write. May result from head trauma or hemorrhage from a shearing of the bridging veins in the subdural space. Coagulopathy, anticoagulation, physical abuse, all use disorder, cerebral atrophy, malignancy are associated with an increased risk of subdural hematoma. Imaging subdural hematoma appears as a crescent shape. Um, Collection abutting the internal surface of the skull, not bound by suture. In some cases, the subdural hematoma may be large enough to compress adjacent brain parenchyma, displacing the cerebral hemisphere. Thus, presentation can include subacute or subacute onset headache, focal neurologic deficit, alterment, status, seizure, herniation syndrome, and signs of increase in cranial pressure, such as vomiting and papilledema. Okay. Patients may manifest oculomotor neuron examination findings, such as we know that elderly patients are at risk for cerebral atrophy, which places traction on bridging cortical veins. In this setting, minor trauma such as falls can result in shearing of the veins leading to hemorrhage. Untreated SDH may continue to grow, and the intracranial compartment is a fixed space with a rigid skull. Pathologic lesions such as SDH can result in midline shift and herniation of central nervous system structures if large enough. When such mass effect is present or at risk of developing, surgical intervention such as decompressive burr holes or craniotomy may be indicated to evaluate the hematoma, to evacuate the hematoma. Next.
Okay. A 77-year-old woman. A 77-year-old woman comes to the physician because of low back pain for 1 year. The pain is worsened by prolonged standing. The pain is worsened by prolonged standing or walking and is partially relieved by bending and partially relieved by bending forward when standing. Okay, tell me your diagnosis.
Mm, the spinal stenosis.
I think so too. Okay. Examination showed decreased range of motion in her back in all directions. SLR is positive at 60° bilaterally. There is slight weakness in the hip flexor muscle bilaterally. Strength in the distal extremity is normal. Deep tendon reflex normal in the upper extremity, but absent in the lower extremity. Babinski sign and absent bilaterally. Which of the following is the most likely diagnosis?
Okay. Guess
Ready?
we'll go with our
Sorry?
initial diagnosis. I guess we'll go with our initial diagnosis.
Yes, that fits.
That
Let's see.
fits. Yeah, lumbar stenosis, lumbar
Conus
spinal
comes
stenosis,
with upper motor neuron, hyperreflexia, exaggerated jerk, isn't it? Conus.
clonus. Uh-huh.
And a lumbar radiculopathy comes with what? Like low back pain radiating to the foot or knee,
Mm-hmm.
like radiation. And peripheral neuropathy is blobs and stockings. Okay.
Yeah. Lumbar spinal stenosis refers to narrowing of the lumbar spinal canal, which results in compression of the lumbar nerve roots and spinal cord. Patients may present with symptoms of radiculopathy, including back pain that radiates to the buttocks and legs, leg numbness, paresthesia, weakness. Hip extension increases pressure in the nerve roots, while flexion of the hips relieves pressure. Consequently, patients may demonstrate neurogenic claudication in which extension of the hips walking externally leads to symptoms. The most common cause of lumbar stenosis is degenerative disc disease, which often occurs with age. The diagnosis is confirmed by MRI. Treatment involves NSAIDs, physical therapy, and surgery. Lumbar radiculopathy can be caused by a dissemination of facet arthropathy and present with pain in a dermatomal distribution, decreased sensation, weakness, eat the corresponding myotone. Patients typically present with burning or shooting pain that radiates down the back of the leg, as well as numbness, weakness, and paresthesia of the foot. Next.
A 68-year-old woman with chronic renal failure has had paresthesia of the feet for 2 weeks. She has been taking isoniazid since positive PPD skin test 6 months ago. Examination showed chillosis and glossitis. Sensation to light touch and vibration and proprioceptions are decreased if tendon reflex are absent of the ankles and buoyancy sign is absent. The most likely cause of the patient's okay.
Sensation to light touch, vibration, and perception are decreased.
Ready?
One
Is
moment.
it pyridoxine?
Pyridoxine is what, B6?
Yes.
Wait, let's see. Yeah. Isoniazid is used in treatment of TB, which results from initial exposure to Mycobacterium TB. So niacin binds to B6, which may result in early excretion and activation of pyridoxine and inhibits yeah. This results in pyridoxine deficiency, and of which primary symptoms are peripheral neuropathy and paresthesia. Pyridoxine deficiency limits synthesis of histamine, hemoglobin, and neurotransmitters, including epinephrine, norepinephrine, dopamine, serotonin, GABA. In addition to peripheral neuropathy, deficiency commonly presents with dermatitis, sideroblastic anemia, glossitis, seizures. These adverse effects may all be avoided by periodontal supplementation in patients taking isoniazid. Next.
A previously healthy 32-year-old woman comes to the emergency department one day after sudden onset cloudy sensation in the left eye and constant pain behind the eye. Cloudy sensation in her left eye and constant pain in and behind the eye. She has no history of trauma. Pupils are 5 millimeter in diameter. There is left afferent pupillary defect visual acuity 20 by 20, 20 by 400 in the left eye. Visual field testing is central scotoma on the central scotoma of the left eye. Fundoscopy examination shows no abnormality. The left eye is not injected. Which of the following is most appropriate pharmacotherapy?
So do we give IV steroid or oral steroid?
I think that it is acute condition. We should give IV steroid.
Okay, let's check. It is IV steroid, optic neuritis, from autoimmune demyelinating inflammation of the optic nerve and presents in young, often female patients with unilateral vision loss and pains that is exacerbated by intraocular muscle movement. Ocular exam discloses decreased visual acuity in color vision, central scotoma, blind spot in the center of the visual field, and relative apparent pupillary defect, a measure optic disc edema. Diagnosis is confirmed by MRI showing hyperintensity of the optic nerve. Patients with optic neuritis are at increased risk for MS. And optic neuritis is a common initial feature. The optic neuritis treatment, blah, 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 demonstrated that the short course of treatment with high dose IV methylprednisolone speeds the rate of visual recovery and delays the onset of MS, although it does not impact the visual acuity, and demonstrated that the presence and quantity of periventricular white matter lesions on MRI is the most important prognostic factor for the subsequent development of MS. Not-oral prednisone is traditionally thought to be less effective than IV prednisone and is therefore less commonly used. This is an area of active research and clinical decision around the ideal steroid choice, dose, and route administration should be based on the most current evidence and standard of care. Okay, next.
Okay. A 50-year-old woman comes to the physician because of 2-year history of intermittent numbness and tingling of his hands. Her symptoms often awaken her from sleep and also occur while she is driving. The symptoms are relieved by shaking her hands. Neurological examination shows no abnormal. Which of the following is the most likely diagnosis? This is CTS.
I think so.
Okay.
Okay, so it is carpal tunnel syndrome. CTS results from compression of the median nerve within the carpal tunnel and presents with signs and symptoms including pain, weakness, and paresthesia of the first three digits, along with both the tinal and phalanx. The carpal tunnel is, we know, by the flexor retinacular up, and the flexor tendons of the fingers course through the tunnel along with the median nerve. The space is rigid and does not permit compression. Thus, any inflammation, traumatic, or space-filling lesion may cause CTS. Patients generally present with pain and paresthesia in median distribution along with weakness involving the muscles of the tender eminence. Symptoms are generally worse at night and relieved by shaking of the hands. CTS is frequently associated with pregnancy, hypothyroid, RA, acromegaly, amyloidosis, ganglion cysts, obesity, acute trauma to the wrist, chronic remodeling, scar formation following wrist injury. Patients with mass symptoms can be treated conservatively with wrist splinting. They are worn at night but may also be used during the day. Splinting reduces the range of motion of the wrist and limits activity that increases pressure to the carpal tunnel. Patients who have persistent and severe symptoms of muscular weakness may require surgical decompression. Next.
A 42-year-old man comes to the emergency department 12 hours after the onset of shortness of breath. 12 hours after the onset of shortness of breath, vomiting, diarrhea, generalized weakness. He has schizophrenia treated with risperidone. He occasionally takes acetaminophen or aspirin for headache. He has long-standing history of alcohol use disorder. He is unemployed and usually sleeps on the grass in the park. On arrival, he appears diaphoretic and is mild respiratory distress. His temperature is 98.6, pulse 120 per minute, respiration 20 per minute, blood pressure 115 by 80. pupil is 2 millimeter and reactive to light. Wheezes are hard. Bilateral muscle strength is 4 by 5. Which of the following is the most likely cause of this patient's symptoms?
Hmm.
Slips on the park. I found such similar question.
You we did.
Yes.
Mm. Ah, yeah, I'm tired. Okay, ready? Ready? Sorry.
Yes. Yes.
So it's organophosphate poisoning. Organophosphates are commonly found in insecticides, and exposure to them can cause transcutaneously or via inhalation or ingestion. Monophosphate bind to and inhibits acetylcholinesterase, preventing breakdown of acetylcholine, which leads to excessive acetylcholine in the neuromuscular junction. Acetylcholine acts as both nicotinic and acetylcholine receptor. Nicotinic receptors are found in autonomic ganglia, adrenal, medulla, and skeletal muscles, whereas muscarinics are found in the heart, brain, muscle, and exocrine glands. Resulting cholinergic excess leads to bronchospasm, bronchoria, bradycardia. Doesn't have bradycardia. Meiosis, lacrimation, and salivation. Because of the potential for anosphosphate toxicity via transcutaneous exposure, medical professionals should always wear rubber gloves when treating the patient. Treatment involves the contamination of the patient along with atropine to antagonize muscarinic receptors and pyridoxine to regenerate acetylcholinesterase. It is not lead poisoning present with cognitive dysfunction, encephalopathy, hearing loss, peripheral neuropathy. Distal motor neuropathy causes lower motor neuron sign, including weakness, blah, blah, blah. Non-neurologic manifestation of lead poisoning include renal tubular dysfunction, vomiting, abdominal pain, constipation, anemia. Okay, next.
Okay. What is your diagnosis?
Oh no, I cannot. I don't know from this. Mm.
Is it adenoma sebaceum? What?
Huh?
Mm, okay. Let's see. Adenoma sebaceum. I am thinking about adenoma sebaceum.
Oh,
What is in his mouth? I have seen this.
oh, I haven't. Yes, I don't.
A 12-year-old boy is brought to the emergency department. By his mother 3 hours after he has realized on a chronic seizure. The mother reports that his seizure lasts for 5 minutes and was followed by a 1 hour period of drowsiness. The patient does not. The, the patient has no history of serious illness, takes no medication. He appears well developed. Temperature is 99, pulse 70 per minute, respiration 20, blood pressure 105 by 75. Photograph of the face and the mouth shown. Which of there is 2 to 3 hypopigmented macule between the scapula. Cardiopulmonary examination show no abnormality. There is bilateral flank masses. Which of the following is the most appropriate next step in evaluation of the seizure?
I have no idea.
Evaluation of this.
Ready?
What you have picked? Karyotype analysis.
I picked CT scan, but I don't know. Maybe you're right. Maybe it's carry. No, I don't think it's carryotype. I'm between CT scan and EEG. I don't know what the bilateral brainstem thingy means.
Okay.
Um, okay, let's see. His CT scan. Neon said, what does he even have? Oh, he has tuberous sclerosis. Sorry.
I di
Neon, huh?
Okay, yes.
I don't know what is this thing in the
It is adenoma sebaceum.
Oh, okay. Oh, that's why you call it. Okay. A new onset. Oh, wait. Let me read it from here. New onset seizure in the setting of abdominal exam, abnormal exam findings such as masses, is concerning with intracranial mass lesions. CT scan of the hand should be ordered. Neurologic manifestations, cutaneous lesion, and palpable masses are suggestive of irritable um, disorder as the cause. Tuberous sclerosis, autosomal dominant neurocutaneous disorder characterized by hematomas, benign tumors in several organs, particularly the skin and CNS. Daniel's findings include ash leaf spots, hypomelanotic markers, angiofibromas of the face and around the nails, acneiform lesions, and chagrin patches, subcutaneous oval nodules, and fibrous plaques on the forehead. Characteristic CNS lesions include glioneuroamatomas, also called cortical tubers, subependymal nodules, and subependymal giant cell tumors. Seizure is the most common declaring presentation of TS. Cognitive dysfunction is common, occurring nearly whatever. Tumors in other organs like cardiac rhabdomyomas, leading to mitral regurgitation and renal angiomyolipomas may be present. Though these tumors are benign, patients are at risk of developing malignancy in soft tissues, brain, and kidney. Diagnosing of TS is typically clinical but may be confirmed with genetic testing indicating mutated TSC. Management requires anticonvulsant medication for seizures and surgical resection of rapidly growing or symptomatic tumors. I guess those are the angiomyofibromas. I don't know. In the face.
They have been described this lesion.
They haven't one? Oh, they have, yeah. Okay.
Okay. Okay, let's stop here.
Okay.